So we're going to run through. I started out, I had about 20 slides that all had all the data from all the studies on them, and I was so bored looking through it myself that I decided you guys can look up those trial information if you like. My only disclosure is I did serve on a Boston Scientific Advisory Board, but I gave all the money away to educational aspects. Transcatheter valves, as the name denotes, are valves that are fixed on a catheter. There are two main types. There's balloon expandable and self-expanding valves. The balloon expandable valves are mounted on the stent, and they're actually opened up by inflating a balloon inside of it, increasing the radial pressure and pushing the obstructed valve out of the way. The self-expanding stents are loaded on with a nitinol cage, and as you release the valve out of the catheter, it will retain its shape within the high temperature of the blood flow. There are also kind of combinations of self-expanding with mechanical support. So the reason for transcatheter valves is really, it kind of sprung from the invasiveness of the aortic valve operation, and is there an easier way? Is there a way of doing it safer? If you look at the STS predicted risk of operative mortality, if you're in the low risk category of less than 5% and you get an isolated AVR, you have pretty good outcomes. By the time you get into higher risk, if you're over 5% predicted risk of mortality, the actual mortality rate in the STS database is up to 10%. And if you're in the 10% predicted risk, your estimated risk is up to 17%. So as your risks are mounting, some of the outcomes become a little bit less predictable. And we know that that in the early trials of TAVR versus whatever medical therapy you can think of for aortic stenosis, which isn't much, in the patients who are extreme risk and could not undergo surgery, those patients did much better with TAVR than they did with sending them to hospice or whatever you do for patients with that degree of severe AS and symptoms. That showed that TAVR was feasible and it could be done in extreme risk patients. The other trials several other trials have been done, and I'm going to kind of summarize the results. The trials have really shown that in patients who are high risk for surgery, meaning an STS risk of greater than 8% or frailty or other reasons that they're high risk for aortic valve replacement, those patients actually in some studies did a little bit better with TAVR, in other studies there was non-inferiority. And so the FDA approved both the core valve and the Edwards Sapien valve for use in patients who are at high risk for AVR. And that high risk was deemed by a heart team with 2 cardiac surgeons and 1 cardiologist. Over time, the results have gotten better. The safety margin has gotten better, and the FDA approval for intermediate risk was based on 2 studies. One major study, the Certavi trial with core valve, and the other trial with the Sapien valve got FDA approval for the Sapien valve, and the core valve approval is right around the corner. So the valve has been approved for intermediate risk, but at the same time we still see some problems with transcatheter valves that we don't see with AVR. One of those problems is paravalvular leak, and some of the early trials had a lot of paravalvular leak. The more recent trials have much less, and you can see here that comparing TAVR to surgical valve replacement, there's a higher rate of mild paravalvular leak, and there's also a significant rate of moderate paravalvular leak. But as the years go on, the level of mild leak gets a little bit better with some of the valves. In the trials the early trials, there were a lot of technical aspects that patients would leave the OR with mild to moderate paravalvular leak that these days probably would not be leaving with that degree of leak. And now with the third generation of core valve and the third generation of sapien valve, the paravalvular leak rates have gone way down. These are the sapien device. This was the original sapien valve, which was delivered in a 22 to 24 French sheath, and very few patients actually had the capacity to have that sheath brought around their iliac arteries, so we ended up doing a lot of these transapical, and that had a lot of increased morbidity to that. The Edwards Sapien XT came out, and that had a smaller sheath, and then the Sapien 3 that actually has a cuff of tissue around the base, and that actually will kind of infold into the irregularities of the calcified aortic valve, and the rates of paravalvular leak are much lower with the third generation. Also the sheath size has gotten much better. There's several valves that are in clinical trials right now. I'm not going to name all of them, but the Portico valve has a different design that hopefully will decrease the rate of pacemaker insertion. The original core valve had a very high rate of pacemaker insertions. Now, as we're learning more about where to put these valves, that rate is coming down, and the pacemaker rate with the self-expanding valves is anywhere from 15 to 24%, and it's trending down closer to the 15% range now. With the balloon expandable valves, it's more on the range of 8 to 10%. You can see here with several design changes, the paravalvular leak rate has come down. This is the Sapien 3 with a 3% risk of having moderate or severe paravalvular leak, and then the direct flow and the Lotus valves have even down to single-digit levels of moderate to severe paravalvular leak. Typically, we try not to leave the OR if we have moderate or severe paravalvular leak. And this is just showing some of the valves on the market, and some of them under clinical trials right now, and their delivery systems. Percutaneous closure, because the delivery systems have gotten smaller, the sheaths have gotten smaller. We've gotten away from transapical access, and we've been able to do percutaneous closure, allowing patients to get through this procedure without being intubated, which is nice for some of the sicker patients. The Tavor Risks are improving the technology. The valve design allows for delivery with a smaller sheath. The percutaneous access and closure is better than it was before. We can avoid alternative accesses more often, and the newer balloon and marker designs make for a more stable deployment. If you've ever seen the S3 deployed as opposed to the original Sapien, we always talked about riding it like a bucking bronco. Even when you're rapidly pacing, you ride that thing in and out of the valve as you're inflating it. The S3 inflates just like that, and you never see it budge. So the deployment is much better. There are more flexible delivery catheters, so you have less injury to the vessels, and new retrievable devices, which by being able to readjust your position even after you've deployed the valve, it will really decrease the rate of paravalvular leak and decrease the pacemaker insertion rate. So is it safe to offer it to low-risk patients? Bottom line, say a lot of things here, but not yet. I think it's reasonable to put them through a clinical trial as long as they're under a very informed consent, but I don't think it's ready for widespread use in low-risk patients yet. Some of the questions about TAVR safety: paravalvular leak, much more rare now. Rarely do we have more than mild. The permanent pacemaker rate we talked about. Vascular injuries are much more rare with the sheaths we have. Stroke rate is 1 to 7%, and in most studies it's actually equivalent or maybe a little better than surgical AVR. valve embolization, aortic dissection, annulus rupture, LV perforation, coronary obstruction are all rare. But if you ever get one of those, you wish you'd never gone into a TAVR room. So those are pretty significant problems. And the big problem is the durability isn't known yet. So you can see here the TAVR valve in the root here and the new dissection that we found in the cath lab. And that's no fun to find. This was a valve that we had deployed, and then all of a sudden you can hear the Halloween music in the background as this thing starts coming down on the echo, and you can see the valve plop down right into the ventricle. And if that ever happens, the most important thing is don't freak out and pull the wire out. So you want to leave the wire in, because you can see here there's another valve deployed right here. And we stuck 2 serrats in through the apex and crunched up that valve, just blindly, sort of under fluoro. I had two serrat clamps and just kind of crunched it up and pulled it out, and we had already deployed a second valve in. And because we had that wire in, it didn't flip over and cause the patient to die suddenly. So this shows, I don't know if you can see it well, but there's a pretty big paravalvular leak here, and that's kind of been sort of the Achilles heel here. So questions do remain about the durability. That won't be clear for some time. We're in the 3rd generation now, so we're only eight years into follow-up data from the 1st generation valves, and those were all done in extreme risk patients. So that's not going to tell us much about degeneration rates. PVL and vascular complications have greatly improved. We have to continue to scrutinize the outcomes and anticipate the setbacks while moving forward with new innovations. So thank you very much.